I always treat my patients through the lens of health span and longevity. So what if I told you about a risk factor in men that had a higher death rate than in women, will happen in 25% of men over the age of 60, is increasing in frequency, and you probably don't know about it? Would you want to know? Well, stick around because we're going to talk about fragility fracture. I just gave it away. Fragility fracture and osteoporosis in men, and how the statistics really paint, honestly, a pretty scary picture that you probably haven't heard of or seen. Why men are actually, I think, at greater risk with osteoporosis and fracture than are women, and what you can do about it now that is unique to men. Stick around. So you might be wondering why I'm a little bit dressed down for this. Well, this is a t-shirt that I got from a recent father-son trip that I did with my middle child, actually, for this one. And I was there with a whole bunch of dads and a whole bunch of sons. And it got me thinking about my male patients. So we are, like I said in the beginning, in the intro, we are always focusing on health span and longevity with our patients. Men have such a different perspective on this than women, and it's really, really interesting. And in the general population, outside of my practice, we find that men just in general don't go to the doctor. They do not pursue medical care. So if you're a man watching this, I'm glad you're watching this. If you're a woman watching this, consider the men in your life, because the men in your life are probably not paying attention to this. You should pay attention to this for them, and here's why. Listen to these statistics. So 1 in 4 men will suffer a fragility fracture in their life, 25%, technically over the age of 60. But 1/3 of hip fractures are in men. So if more women are developing osteoporosis than men, but 1/3 of the hip fractures are in men, that means that men are disproportionately suffering from a hip fracture more so than women. And on top of that, men are twice as likely to die after a hip fracture than are women. That's an interesting statistic. Also, men are less likely to restore independence after a fracture. So men will be more likely to die. They're more likely to become dependent on others or to lose their independence after a fracture. And what's really crazy about this whole thing is that only 20% of men that suffer a fracture like that end up getting tested or treated for osteoporosis. It's just like it doesn't exist. So I think it's really important that we understand some of the numbers around hip fractures, osteoporosis in men, so that we can really dig into the difference between how we look at osteoporosis in men versus women. Now, this is a total flip of what is usually the issue in medicine, which is we have, over the past several decades, just treated women like small-framed men, and clearly that's not the case. But actually, in this case, it's a little bit flipped, where we tend to just treat men like bigger women. And we shouldn't do that either. So it's wrong on both sides of the coin. And so we're going to talk about some differences that we can really look at, some things that we can try to do in men, and how we specifically treat men different than women when it comes to bone health and osteoporosis. So when it comes to men and women in osteoporosis, a couple of differences to understand. So men start with more dense bones. They start with thicker bones, and it is because they have a larger frame. Also, they tend to carry more muscle mass. When you are bigger, you should have stronger bones, although not always. This is important because as we look at the changes that occur through life, we know that women will start losing bone mass in their 30s, maybe 40s. Men start a little bit later after that. And part of the reason why men don't usually have fractures till later in life is because they don't go through menopause. So women go through a very predictable pattern, although the time frame is a little wonky and unpredictable. But overall, most women, unless surgically or otherwise interfered with, will go through menopause somewhere between mid to late 40s and mid 50s. And the loss of sex hormones is very predictable. It is like a cliff. And so men don't go through menopause. Men go through andropause. So andropause is the slow loss of testosterone, the primary sex hormone in men. The slow loss of testosterone over the course of several decades. So you could argue that actually that's protective because they have testosterone and they're not going to develop fractures till later. But what I'm seeing in my practice of health optimization is a tidal wave of men with low testosterone starting in their 30s, maybe even 20s. And it's not just kind of low, it's really low. So I think what we're going to see, we have an entire generations, probably is more accurate, of men that have very low testosterone that's being inappropriately treated, in my opinion, and they are going to go on to develop bone loss and osteoporosis at a much earlier age than they would otherwise. So let me tell you a story about a patient. So Bob is one of my kind of earlier male patients, and he actually has such a fun story that I put him in my book. If you haven't read my book yet, look for the link in the description below. You can download the free ebook, or you can go on Amazon and buy the physical book if that's your thing. He's in the book. He's towards the end. So he's a 62-year-old attorney who is now retired, actually. And he came to me after losing weight with my wife's company, PhD Weight Loss and Nutrition. Had a great experience, got to his goal weight, and wanted to work with me because he wanted to maintain his weight loss. And he also had some other health concerns. He had a history of some kind of liver issues and metabolic disease. And so he just wanted to make sure that everything was dialed in. Wanted to test his hormones and his thyroid and do the whole thing. So that's our bread and butter on the health optimization side. So when we did that, he at the same time got a repeat DEXA, and now he has a history of osteopenia, but now he has osteoporosis. It wasn't a big shift, actually. He just didn't recognize that this was a problem until he had the actual diagnosis of osteoporosis. And so over the course of 2 years, he went from a negative 1.8 to negative 2.3 and negative 2.1 to negative 2.5 T-scores in his hips. So, not terrible, but meets criteria. Now, he also has a history of low testosterone, but he also has a history of alcohol use, inflammation, GERD, and PPI use. We decided to actually flip Bob. So he was not a bone health patient out of the gate. And so we kind of flipped him over to the bone health side and got additional labs, and we set him on his bone health journey. Now, if you don't mind, one of the things that helped Bob to find us was not actually because my wife's company is my wife's company, but because he was doing research online and he found our YouTube channel. If you would be so kind to help other people find us, if you could click the like, subscribe buttons and share this with people who you think would benefit from it, that'll actually help to push YouTube to deliver this to more people who are doing searches for osteoporosis and osteoporosis related content. Also, Bob joined our Masterclass, which is free. You can find a link for the description for that below. And that's, again, one of the ways that he found that he really needed this extra help to get to where he wanted to be and signed up for our services. If you want to hear more about those, just click this link and you can get scheduled to talk to our team members. We had this conversation with Bob because of his history, because he was very curious, why do I have osteoporosis? And of course, this is what we do. We have our 4R framework, and we want to recognize why you're losing bone. So we talked to Bob about his alcohol use, about his PPI use, his gut dysfunction, his low testosterone, his stress that he had in his life. I think all of those things were part of it. Now, fortunately, he's retired. Some of those things have changed. He stopped drinking. We got his gut working. But we had this interesting discussion around testosterone. And initially, his testosterone was okay. It wasn't amazing, but it was okay. So we didn't treat it out of the gate. So this was not part of his original treatment plan. But I want to impart this to you because testosterone is a little bit misunderstood when it comes to bone health. So when we think about bone health, most people think estrogen, right? You take estrogen, it tells the osteoclast to stop breaking down bone. And if you lose estrogen, you rapidly lose bone in menopause. All true. But men don't have that much estrogen. They do have some, and they need some. The way that they get estrogen is from production of testosterone. Men produce a very, very minute amount, but most of the estrogen that they get comes from testosterone converting, or aromatizing is the name of the enzyme, aromatizing to estrogen. And we know then that estrogen will have that impact on bone health and on arterial health and brain health and all the stuff. So that's why men need adequate testosterone. It's not just the testosterone. It's not just what testosterone does. It's that testosterone will then aromatize to estrogen, and then you get all the benefits of estrogen. So we need testosterone not only for muscle mass, and testosterone also has a direct impact on bone, but we also need testosterone to aromatize into estrogen so we can then have the benefits of estrogen just like women, but we have to get it through our testosterone. All right, so I want to talk a little bit about how testosterone can impact bone health, because this has been studied well in men, as I've talked about before in different videos. there's a study from 2006 that's actually a meta-analysis of RCTs, or randomized controlled trials, on testosterone. This 2006 study is interesting because it goes through what was really arguably kind of the best evidence at the time. But here's what's interesting about that. If you look at the conclusion, they talk about these 8 trials. So they found 8 trials that enrolled 365 patients. Come on, 365 patients. I just did a video on the Women's Health Initiative that had 160,000 women in it. So, okay, we got 8 trials with 365 patients. Clearly, those are not very big. And they talk about changes in bone mineral density, and they talk about changes in fracture risk. So what did these trials show? It showed that there was actually a relatively significant increase in bone mineral density, 13% in the spine and 9%, up to 9% in the femoral neck. They talk about these being either significant or non-significant, and how there was some heterogeneity. And what that means is that some studies showed benefit and some didn't. In my opinion, when I look at these studies, and I've gone back and I've done this to look at what the actual intervention is, I think it leads to the conversation around how we treat low testosterone in the traditional medical system, which is with not enough testosterone. And it has to do with this whole concept of what is optimal versus what is considered low. But before I get to that, they also mentioned in this trial that, or in this meta-analysis, that no trials measured or reported the effect of testosterone on fractures. Well, why the heck not? And it's because the trials were way too small to show a difference, and they didn't follow them for long enough. So usually these are a year long, and they're looking for bone mineral density as their primary endpoint, and they're not really capturing fracture data. Now, fortunately, there are studies looking at testosterone and fracture data, but they are actually on women. We'll talk about that in a minute, but let me talk about this idea, this concept of optimal testosterone levels versus low testosterone in our traditional medical system. So if you look at the diagnosis, what is hypogonadism? You have to be under, and this is always changing, so it's somewhere around 300. I think now it may even be 290, and I'm sorry, I don't know the units off the top of my head. So in the US might be different from other countries. But 290 is really low, like crazy low. And men are most likely going to be symptomatic of low testosterone. So what does that mean? Well, symptoms of low testosterone, a lot of times people just automatically think of the sexual benefit. They think of libido, they think of erectile function, but that's not really what most of my patients are after, although that's a nice side effect. What most of my patients are after, they're after energy, vigor, mental clarity, improved sleep, improved body composition, actually improved metabolic factors, improved lipids, cholesterol, cardiovascular risk, lowered blood pressure. The list goes on and on and on and on, the things that testosterone is associated with when optimized. So when we look at symptoms of low testosterone, clearly men under 290 are going to potentially be symptomatic. But I also see those same symptoms, and those same symptoms get better with men that have symptoms with total testosterones in the 300s, the 400s, the 500s, maybe even above that, although that gets controversial. The thing here is that if you go to your traditional medical doctor and you have a total testosterone of 450, they're going to tell you 2 thumbs up, you're good, go away. And you might be. Not everybody that has testosterone in the middle of the range has symptoms of low testosterone, but it is more complex than total testosterone. We have this thing called SHBG, sex hormone binding globulin. In your body, the hormones, testosterone, aren't just floating around waiting to attach to things. They are mostly carried around on SHBG, a little bit on albumin, another protein. They are carried around on these proteins, and there are some testosterone molecules that are free. Those free testosterone molecules are the things that then bind to receptors and go through the cell and do all the stuff that testosterone does. If you're not measuring total testosterone and free testosterone and SHBG and estradiol, arguably, and possibly DHT, you're not getting the whole picture. And if you're just measuring total and you have symptoms of low testosterone, you really need more information. So when I hear people say, I went to the doctor and they checked my testosterone, they said I was fine, and then I start asking about symptoms, it gets really frustrating. So in my practice, we ask about symptoms, we check all of those things, and we come to a consensus about, hey, maybe we should try to treat this through one of 3 ways. We either treat it through hormone optimization, through herbs, through lifestyle, through the supplement pathway. We could potentially do some other medications or peptides, or we go into replacement. it's such an interesting and fun conversation, because just like there is controversy around estrogen, I think there might be more controversy, although less research, on testosterone. So let's talk then about this next study, which is testosterone and estrogen treatment in women, and then talk about how we can then potentially extrapolate this to men. Okay, so there was this study on women that was published in 2008, and it's called Testosterone Enhances Estradiol's Effect on Postmenopausal Bone Density and Sexuality. Now, you might be wondering, why would they study sexuality and bone density in the same study? This has to do with what the FDA has approved testosterone for in women. It is only approved for women with sexual dysfunction. And so if you're going to do a study and use testosterone, you pretty much have to do it for an FDA approved indication, which would be sexual dysfunction. And while you're at it, you could also look at the benefits of bone density. They actually also tested some other stuff. So let's talk about this study. Now, this was a prospective study. It was a randomized control trial, and there were 32 women that completed the study. So again, it was a really small number, but it was powered enough, interestingly, it just shows how big the differences were, but it was powered enough to show a difference between an estrogen arm and an estrogen plus testosterone arm. So here we go. There was substantially greater increase in bone mineral density in the estrogen and testosterone group that was statistically significant in both the vertebral area and the trochanteric area, which is the top part of the femur. And so BMD better in testosterone than in estrogen alone. Now, then they go on to talk about the sexual parameters, and I'll just mention them because they're in here. And so the addition of testosterone resulted in significantly greater improvement compared to estrogen for sexual activity, satisfaction, pleasure, orgasm, and relevancy. Now, I don't know what relevancy means in context of there, but there it is. They also talk about improvement in total cholesterol and LDL cholesterol, and that HDL went up. So, overall, I would say that for this group of women, that testosterone, in addition to estrogen, showed some really promising results. Now, you could argue, well, hey, they didn't actually talk about fracture risk. Again, not enough people, not enough time. All right, so in conclusion, what is my one thing that I really want to talk to men about? It's testosterone. Now, when we think about testosterone, I always end up getting stuck in this, even in myself, this visual image of really yoked guys working out and, looking ripped and looking like they're 20 years old. And yeah, that's a thing. And yes, people use testosterone, likely super physiologically, to achieve some pretty amazing aesthetics and other performance enhancing measures. However, that's not how we're using it in our practice. And that's not what our goals of our patients are. For men with osteoporosis, men at risk of fracture, testosterone can be such a powerful tool. And I think it's so important to understand the difference between optimal testosterone and the traditional medical model of hypogonadism or low testosterone. They are very, very different. And talking to somebody who understands that difference is absolutely critical. Here's my concern about men. Men are actually at higher risk of death, disability than women are from a hip fracture. Men are not being tested. Men are not being considered for treatment. A great example is my father-in-law, who will probably never watch this video, so I can just talk about him openly behind his back. Love the guy. He's a great guy. But I look at him and I consider him similar to actually Bob, who I'll tell you a little bit more about. But I see this entire generation of men who are losing muscle mass. They're not being adequately managed. They're being told that their testosterone is fine, and it's not. They're being misguided from a dietary perspective, and they're just withering away. When you wither away and you have no metabolic reserve, when you suffer a fracture, you're at high risk of death. I mean, it's just that simple. And I see these guys, and it's not even just a hip fracture. It could be any fracture. I've seen a tibia fracture in an 80-year-old that ended up in his death, right? He just couldn't recover. He had no metabolic reserve whatsoever. Watch this guy with this really benign fracture that the surgery went just fine, and he did fine with anesthesia. And literally, 3-4 weeks later, he was dead. And so I see this over and over again, and I want to treat my men and my practice much differently. And I hope that you demand that for yourself, or if you're watching this for a loved one, that you demand that for them. Now, aside from that, men are not dissimilar from women in things like gut dysfunction, the need for lifestyle improvement, stress, sleep, understanding what kind of exposures you have, metabolic dysfunction. So the approach that we take is still based off of the same framework, right? So we use the 4R method to understand why people are losing bone, reverse those causes of bone loss, retest to make sure we're going in the right direction, and then revive their life and help them live without the fear of fracture, the 4R method. But it's the health optimization pyramid that really underscores how we manage these patients. So it's very, very similar from men to women. So starting with lifestyle and then moving on to targeted based off of biometrics, biomarkers, and genetics. So custom supplementation, and then having a conversation about hormone optimization or replacement, and then talking about peptides. And then, and only then, are we talking about drugs. So based off of that, what did we do for Bob? Well, we were focusing on so many things for him. And one of our biggest goals was to maintain his weight loss. So we were very careful in how anabolic we pushed him. And he was very concerned about gaining weight back, which is fine. So we had to be just very cautious in how aggressive we were from a protein intake perspective and how many calories. So we really had to play this body composition game. Now we know that building bone and building muscle and either losing weight or even sometimes maintaining weight can be a difficult balance. Whenever we're trying to be anabolic, it's hard to also be catabolic. Possible, but challenging. And so we went on this pathway with him and we put him through the optimization period and we did all those things. And at 6 months, he reached out and he said, hey, I want to do another REMS. Now he did this initial REMS, which is the Echolite REMS. If you haven't seen that video, you should check it out. But he did his initial REMS, which actually showed that his T-score was worse than his DEXA showed. His bone density was reasonable, but it actually scared him more than anything. He was happy to see his bone density wasn't terrible, but it's still, his T-score was -2.7 on his REMS. So at 6 months, he wanted to do another one. And I said, Bob, I don't think this is a good idea, man. And the reason why this isn't a good idea is because at 6 months, even if you're doing all the right things, you haven't really remineralized much, if anything, in your bone. And so a REMS might actually look worse before it looks better. And he did it anyway. So thanks, Bob. He did it anyway, but to both our surprise, he saw actually pretty tremendous improvement. So his T-score in his hip went from -2.7, this is right hip, to -2.4. His spine went from -2.6 to -2.4. That's a 12% and an 8% improvement, respectively. That's better than a bisphosphonate after 2 years of therapy. That's better than anabolic drugs. It's better than Divinity. It's better than all of them, right? And so pretty remarkable. His CTX, which is the biomarker of bone breakdown, his CTX went from 494, pretty high, to 151. Yeah, Bob. And his P1NP didn't really change as much as we hoped. And so this is why at that visit, we were happy, high-fiving virtually through Zoom, stuff like that. At the 6 month mark, we changed things a little bit and decided to get more anabolic. So we switched up our peptide protocol. We actually did go on testosterone because even though initially his testosterone was okay, it wasn't great. When we rechecked, it was pretty terrible. And when he had been thinking over the last 6 months of symptoms of low T, he really did have many of them. So we ended up replacing testosterone, and that's going to have a significant impact on his P1NP and metabolic side of things. So now he's lifting heavier. He's doing all the things. I think I can't wait to see his 12-month numbers and his 12-month REMS, because I'm sure he'll do one. So anyway, if you found that helpful and this is a journey that you think others would appreciate, please do the things, the like and subscribe and sign up for notifications if you want to know when we put out videos. If you could share this with people that would be interested in this type of information, particularly men who have their head in the sand. It's not a slight on men. I am one. I get it. Just let them know. This is something that should be on their radar. If you are interested in our masterclass, learning more about how you can handle osteoporosis on your own or other tips and tricks, look for the link in the description below. If you want to chat with one of our team members, then you can click this link and you can get scheduled with one of our team members to talk about our different program options. If you haven't read our book yet, then you should read our book. I got it right here. So the Osteoporosis Breakthrough. You can click the link in the description and that'll send you to the download page. You should be able to download that book for free. If you want to read the physical book, you can buy it from Amazon. We have it listed at a relatively low price. We're just trying to cover the cost there, trying to get that into as many hands as possible. And then lastly, if you haven't left a comment or question for us yet, please do so. We love the engagement, the interaction. My team and I will do our best to get through comments on a timely basis, but we do love all of the interaction and the community that we're building on YouTube. So thank you for that. And I do look forward to your comments, your questions, thoughts of other topics that we could discuss. And that brings us to the end. So thank you again for your patience. I hope you found this helpful, and I will see you on the next video.